Welcome, welcome. Medicosis Perfectionalis is here, where medicine just makes perfect sense. We continue our discussion about pulmonology playlist. In the previous video, we talked about pleural effusion. Today, we'll talk about lung cancer, a horrible disease and an awful topic to discuss today, but this is science, and this is how we help patients. Okay, there are two locations of lung cancer. It could be bronchogenic, or it could be alveolar. Today's topic is bronchogenic carcinoma. It could be central, such as small cell cancer or squamous cell cancer, or it could be peripheral, such as adenocarcinoma and large cell cancer. With that being said, now let's get started. Cough and dyspnea equals respiratory problem, and you have 5 options: obstructive, restrictive, pulmonary vascular abnormality, infection, or malignancy. Malignancy includes bronchogenic carcinoma, alveolar cell cancer, and metastasis. We will talk about bronchogenic carcinoma and metastasis today. Here are 30 questions. If you can answer these 30 questions correctly, probably you do not need to watch this video. I should be learning from you. Please try to answer them. You can find all these answers throughout the video. Cancer statistics. What's the most common overall cancer in the United States? And the question did not say male or female, and the answer is going to be skin cancer. What's the most common cancer in the United States in females? Breast. In males, prostate. Because females do not have prostate, males do not have big breast, but both of them have skin. That's why skin is the most common cancer overall. What's the second most common cancer in females in the United States? Lung cancer. Second most common in males? Lung cancer. Third most common in the United States in females, colorectal and colorectal. But this is the United States. If we are talking what's the third most common cancer worldwide, the answer is hepatocellular carcinoma. I came from Egypt, and there is a lot of hepatitis B and hepatitis C in Egypt, increasing the risk of hepatocellular carcinoma. So in the United States, here is the deal. Here is the incidence, and here is the mortality. Number 1 is breast/prostate. Number 2 is going to be lung. Number 3 is going to be colorectal. All right? Mortality, you switch 1 and 2. Number 1 common cause, or the most common cause of cancer-related death in the United States, is lung. Second most common is breast/prostate. Breast in female, prostate in male. Colorectal is always number 3, if we're talking in the United States. Why did lung cancer, although the second most common, became the first most common cause of cancer-related death? I'll tell you why. Number 1, it's very difficult to screen. Number 2, many patients are asymptomatic. Number 3, it's rapidly progressive and rapidly fatal. Most common cause of cancer-related death in the United States, lung. Second most common, breast or prostate. Third most common, colorectal. Lung cancer among different ethnicities. If you are a young student just getting started, then skip the slide. But if you are a resident, you need to know this. Since the lung receives 100% of the systemic circulation through the right ventricle, secondary lung cancer is more common than primary lung cancer. By secondary, I mean metastasis. Where is the metastasis coming from? Breast is the most common. So this is primary breast cancer going to the lung. We call this metastatic breast cancer. Then when it goes to the lung, we call it secondary lung cancer. Next one is colon cancer. Third one is renal cell carcinoma. So if you have a female with secondary lung cancer, play odds. Where is it coming from? Breast. If you have a male patient with same problem, secondary lung cancer, where is it coming from? Colon. Just by statistics, but of course you will need more tests. Once they arrive at the lung, where do they go? Lung parenchyma is the most common one, pleura, endobronchial mucosa, and lymphatic. What is the most common symptom if a patient has secondary lung cancer? Dyspnea. Primary lung cancer. In males, the incidence is declining. In females, the incidence is increasing, but still, the incidence is higher in men than women. So let's say this is the curve for men. The incidence is decreasing. And here is a graph for you. And here is time. Okay, and here is incidence. This is the male graph. Female graph is like this. It's increasing. But still, until now, it's commoner in men than women. Why is the incidence decreasing in men and increasing in women? I have no idea. I have some theories, but most of my theories are wrong, so don't take my word for it. Ask an expert. The incidence rate is highest among black males. The peak incidence of lung cancer is between 55 to 65 years of age. What's the average? You know how to calculate the average or the mean? You get 55 plus 65 divided by, you have two numbers here, so by 2 equals 60 years of age. That's the typical patient. Cancers in general are disease of the elderly, and there are exceptions to every rule. Survival rate of lung cancer is among the lowest of all cancers, difficult to screen, many patients are asymptomatic, and they are rapidly progressive and fatal. Primary lung cancer is divided into non-small cell lung cancer, also known as NSCLC, and small cell lung cancer. This is the majority of lung cancer. This is just a minority, but they are very bad. They are very progressive, and they are rapidly fatal. Non-small include adenocarcinoma, squamous, large cell, and bronchial carcinoid. Of these four, which one is the most common? Adeno. If you are talking about adults. Okay, I'm talking about children. What's the most common one? Bronchial carcinoid. What is the most common symptom if a patient has primary lung cancer? It's cough. What are other symptoms? Weight loss has to be unintentional, more than 10% of total, and in a short period of time. Chest pain, hemoptysis, shortness of breath, symptoms of hypercalcemia if a patient has squamous cell lung cancer because it secretes parathyroid hormone-related peptide. Parathyroid hormone-related peptide acts exactly as a parathyroid hormone, increasing calcium by 3 mechanisms. Increase absorption, increase resorption, increase reabsorption. Absorption in the GIT, resorption from the bone, reabsorption from the kidney, specifically the distal convoluted tubule, particularly the principal cell. Okay, symptoms of hypercalcemia: groans, thrones, stones, psychiatric overtones, and phones. Groans, I mean constipation and abdominal pain. Thrones, polyuria. Why? Because there is increased calcium in the plasma, there will be increased calcium in the urine. Stones, calcium, kidney stones. Overtones, psychiatric issues. Phone, because sometimes hypercalcemia can lead to acute pancreatitis, and acute pancreatitis is a medical emergency. You need to call 911 if you are in the United States, or 999 if you are in the UK. I'm an Egyptian guy. I lived the majority of my adult life in Egypt, and I'm not sure what the phone number of the police is. That's how horrible I am. Signs of primary lung cancer: tachypnea, clubbing, Horner syndrome, muscle weakness if there is Lambert-Eaton myasthenic syndrome, especially with small lung cancer. This is a paraneoplastic syndrome. In the good old days, hypertrophic pulmonary osteoarthropathy was considered type 4 or grade 4 clubbing, but now they are two separate things. Clubbing is just the nail clubbing, but then pulmonary osteoarthropathy is like when you have wrists that are very thick because of the osteoarthropathy and new bone growth, and this is commonly seen with lung cancer. If your lung cancer is at the apex, you can have Horner syndrome because there is a sympathetic chain here and this tumor can press on it. You can have upper extremity weakness and shoulder pain because there is a brachial plexus passing nearby. This brachial plexus contains some sensory fibers leading to shoulder pain and some motor fibers leading to upper extremity weakness. The most important point in this entire video is that cigarette smoking is the #1 risk factor for primary lung cancer. Also, we have radon gas, asbestos, coal dust, irradiation, air pollution, uranium, some metals such as these, and I have a mnemonic about my brilliant son. It's one of my medical jokes. Check out my playlist called Medicosis, Medical Jokes, tuberculosis, rheumatological disease, and even silica exposure. Pathogenesis, gain of function, such as oncogene, loss of function of the tumor suppressor gene. Oncogene, genesis of oncology, they cause cancer, such as all of these are involved in lung cancer. Tumor suppressor gene are the opposite. If oncogenes are the accelerator in your car, they accelerate the formation of cancer. Tumor suppressor genes are the brakes of this cancer. If you have them, you are less likely to have cancer. If you inhibit them, your brakes are not working. The accelerator is going into overdrive, leading to cancer. So if you have problems with P53, retinoblastoma 1 or RB1, and P16, you have increased risk of lung cancer. Common sites of metastasis include hilar lymph nodes. Remember, we call them bronchogenic carcinoma, and a carcinoma loves to go to the lymph. They will go to the hilar lymph nodes, and it's gonna be painless. Because cancer is painless, infection is painful. This is, of course, is theoretical because you cannot palpate those hilar lymph nodes. They are hiding underneath the sternum. Lung cancer loves to go to the adrenal glands, to the liver, to the brain, and to the bone. This is the most important table in the entire stinking video. Okay, adenocarcinoma, squamous cell carcinoma, small cell cancer, also known as oat cell carcinoma, large and then bronchial carcinoid. Percentage of cases, the majority of them are adeno. Adeno is the most common one in adults. How about the most common one in children? It's bronchial carcinoid. Okay, location of adeno, peripheral. Squamous is central. Small is central. So squamous, central. Small, central. Large could be either one. Bronchial carcinoid could be either one. Link to smoking is very weak. Link to smoking, strong. Again, small and squamous, central, and they are related to smoking. Large is also related to smoking, and bronchial is not related to smoking. Let's talk about adeno, commoner in females than males. Slow growth, but early metastasis. Horrible. So these poor women who never smoked develop an adenocarcinoma that grows slowly, so they are asymptomatic, but it's early metastasizing, so they die very soon. Horrible. Associated with KRAS oncogene, grows on old scars such as tuberculosis and interstitial pulmonary fibrosis. There is a subclass called alveolar carcinoma in situ or bronchoalveolar carcinoma. Back in the good old days, which were not so good, this was a separate disease, but now it's a subclass of adenocarcinoma. What is the big deal? It arises from Clara cell or type 2 pneumocytes. In other words, it arises from the stem cells. The stem cells of the alveoli are the type 2 pneumocytes. The stem cells of the bronchi are the Clara cells. I'm sorry, Clara cells are in the bronchioles, not the bronchi. The patient may cough cupfuls of frothy sputum. So here's the deal. Cupfuls on your exam, they will describe a patient as coughing cupfuls. If they just say mucus, this is chronic bronchitis. If they say cupfuls of pus, this is bronchiectasis, or pleural empyema, or parapneumonic effusion causing pleural empyema, or lung abscess. The question described as cupfuls of frothy sputum, this is lung cancer. Also, it could be pulmonary edema, same frothy sputum, but usually not cupfuls, but again, remember frothy sputum, it's either pulmonary edema or lung cancer. Mild cases are misdiagnosed as pneumonia. Horrible. Again, these ladies die because doctors, it's very hard to diagnose this disease, and it has early metastasis. Severe cases, when you look at the chest x-ray, it can be misdiagnosed as ARDS. Next, squamous, 25%, central, associated with smoking, male commoner than females, cavitation, local extension, linked to atelectasis or pneumonitis. Late metastasis, not early as adeno. P53 secretes parathyroid hormone-related peptide leading to high serum calcium but low PTH, because this is a negative feedback. Very common question in your exam. The students will find increased calcium and low PTH. Then what's going on here? And the patient was smoking, and they do not connect the dots. This is squamous cell lung cancer, and my mnemonic is squamous, has the K sound, will lead to hypercalcemia, which has the K sound. Will also lead to cavitation, which has the K sound. Next, small cell lung cancer, 20%, central, associated with smoking. Males more than females. Neuroendocrine cells or APUD cells in the lungs, they are called Kolchitsky cells. They are small and dark blue under the microscope, associated with the MEK oncogene, P53 and RB1 tumor suppressor genes. Rapid growth, early metastasis. Small is horrible. Secretes ACTH leading to Cushing syndrome. Don't say Cushing disease. We only say Cushing disease if it's coming from the pituitary. And or ADH, this is called SIADH, associated with Lambert-Eaton myasthenic syndrome leading to muscle weakness. The problem is in the presynaptic calcium channels when you have O2 antibodies destroying them. It's positive for chromogranin A, neurospecific enolase, and synaptophysin. Who named these things? Large cell cancer, 10%, could be central or peripheral, associated with smoking. Early metastasis, it loves going to the mediastinum, to the brain, to the recurrent laryngeal nerve, causing hoarseness. So a patient who has cough, dyspnea, and hoarseness, please be very careful. This could be cancer, lung cancer. Superior vena cava syndrome, as we'll discuss later. Undifferentiated, these cells are large, and as you know, if you have watched my videos on leukemia, you know that large cells are immature, and this was the difference between chronic leukemias and acute leukemias. But if you give them time to differentiate, they will differentiate into squamous cell carcinoma or adenocarcinoma. Last one is bronchial carcinoid, 5% in adults, but it's the most common one in children. Male equals female. Neuroendocrine, it's called the iceberg tumor. It infiltrates the wall of the bronchi like an iceberg infiltrating Titanic. And the tumor will, quote, fan out. I'm not a fan. Cough, hemoptysis, carcinoid syndrome. So this is increased serotonin. You have diarrhea, flushing, hypotension, etc. And maybe wheezing. 5-HIA level in the urine because this is a product of serotonin metabolism. Here is a very common myth that I would like to debunk. People say, doctors will not screen you for lung cancer. Wrong. Doctors will not screen every patient with lung cancer. Okay, so how do you scan it? Low-dose computed tomography. How often? Annually. For whom? For everybody? No. And this is the reason for this misconception. Patients who are between 55 to 74, because the typical age of presentation is around 60, who have smoked for 30 pack years and still smoke, or have stopped smoking during the last 15 years. What the flip is a pack year? Because you hear that term all the time. Here is the pack year. You ask the patient, how many cigarettes do you smoke per day? You divide that by 20. Why 20? Why not 10? Why not 15? Why not 35? Because typically a pack of cigarettes contains 20 cigarettes. Ooh, how did you know that, medicosis? Do you smoke? I've never smoked a cigarette in my life. Maybe you are paid for by those big tobacco corporations. Have nothing to do with them. I just learned that because I need to calculate this. Let's say a patient, doctor, I smoke around 20 cigarettes a day, which is about like, I smoke a pack a day. Okay, 20 divided by 20 is 1. How many years have you been smoking, sir? I've been smoking for 35 years. So a pack a day for 35 years equals 35 pack year. Is this greater than 30? Yes. This patient should be screened for lung cancer. How would you screen them? Low-dose CT scan. How often? Every single stinking year. Be very careful of false positives because false positives ruin lives. You will say to your patient, sir, I have some bad news for you. I saw a nodule in your lung on low-dose CT. It could be cancer. It could be benign. We will need to do a biopsy. You tell the patient that and he will start with denial, which is a defense mechanism. Then he'll start reading hundreds of online blogs, which is another defense mechanism called intellectualization. Then he'll take a second mortgage on his house, lease his children, spend all his money on divorce attorneys because his wife is not putting up with his BS. And then the result of the biopsy comes back negative. It was a benign hamartoma. And now he's broke, without a house, lost his children, missed his wife, and he is a convicted felon. Well done, doctor. Well done. How to diagnose lung cancer? You need a detailed medical history and a thorough medical exam. If the patient is in the risk group, you need more tests. What do you mean? CBC, CMP, LFTs, which are AST, ALT, and bilirubin, alkaline phosphatase, and sputum cytology for cancer. Radiology, contrast CT scan. Of what? Of the chest, abdomen, pelvis. Why chest? Because of the lungs, the mediastinum, the pleura, and the lymph nodes. These are involved in lung cancer. Abdomen, liver, and adrenal could be the source of the cancer, or it could be a secondary to lung cancer. Pelvis, such as colon cancer, because colon cancer can metastasize to the lung. If you suspect lung cancer, please do more tests. How do I know? Peripheral masses are usually adenocarcinoma or large cell. Central masses are squamous or small. In adenocarcinoma, the patient is usually a female. In squamous cell carcinoma, it's usually a male smoker with hypercalcemia. In small cell, it's a male smoker with Cushing disease or syndrome of inappropriate ADH or Lambert-Eaton myasthenic syndrome. PET scan can be helpful. What's the flip is a PET scan? You inject the patient with glucose. Those cancer cells, they will eat a lot of glucose. When they eat glucose, they will shine on the screen. This is the idea of the PET scan because cancer cells are active. That's why they grow rapidly and kill you. PET scan is excellent, even better than CT scan for mediastinal masses and distal metastases. MRI and CT scan of the brain because lung cancer can go to the brain. How about chest x-ray? Not for lung cancer, baby. But I thought that we would start with x-ray, then we will go to the CT scan, then okay, let's say we started with the x-ray and you saw something that you are not sure about. What's the next step? CT scan. Then do the CT scan right away. Why waste your time and money on 2 tests when you can just do one? Think, people. X-ray has a sensitivity of 74%. This is dismal. This is horrible. Sensitivity is low. Therefore, the ability of chest X-ray to rule out the diagnosis is low. It's not a good screening test. Forget it when we talk about lung cancer. Why do we use CT scan for screening? Because the sensitivity is 94%. Because that's a very common question on your exam. They will give you a patient with lung cancer and they will ask, what's the next step? Most of you will choose chest X-ray. You are as naive as a B lymphocyte before it recognizes the antigen. The answer should be CT scan, folks. Tissue biopsy, what's the approach? You can do it through bronchoscopy with transbronchial biopsy, mediastinoscopy, lung needle biopsy, thoracoscopic lung biopsy, or even open lung biopsy. What's the rationale for the approach? It's based on the location of the flipping cancer. If the problem is in the mediastinum, you can do a mediastinoscopy. If it's a central cancer, you can do bronchoscopy. What if the mass was supraclavicular and you were able to palpate and auscultate that in a high-risk patient? What should you do next? Fine needle aspiration biopsy or excisional biopsy. This will help you in diagnosis and staging. Because remember, staging, I have a song. Staging is by physical exam and CT scan. And of course, biopsies can help. What if you find pleural effusion associated with cancer? You can do pleural effusion cytology. You tap the pleura called thoracentesis and send the fluid to the lab to obtain cytology. Historically speaking, we used to do closed pleural biopsy. Not anymore. It's 2019. You can do molecular markers for sputum, you can do bronchoalveolar lavage, and you can do PET CT scan, preoperative staging for non-small cell lung cancer. Why not for small cell lung cancer? Because small cell cancers are inoperative. You cannot do surgery for small cell lung cancer, and my mnemonic is terrific. Small cancers are very small that even the surgeon cannot see them. Staging for non-small cell lung cancer, this is the 8th edition. Some of you have the 7th edition. You should update yourself. Primary tumor is T, regional lymph node is N, distal metastasis is M. We call this T and M classification. T, if the tumor is less than 3 cm and it's not invading the main bronchus, this is T1. T2 is the tumor between 3 to 5. It's not invading the entire lung. 3 is between 5 and 7, or if it invades the diaphragm, the chest wall, the mediastinal pleura, or the pericardium. It can involve the main bronchus, but not the carina. Stage 4 can involve the carina. It's usually 7 cm, or it invaded the mediastinum, the heart, the great vessels, the recurrent causing hoarseness, etc. N, the lymph nodes. N0, no metastasis to any lymph node. There is no nodal involvement. N1, there is metastasis to the ipsilateral lymph node. N2 is metastasis to the ipsilateral lymph node, could be mediastinal or subcarinal. N3 is metastasis to the contralateral lymph node on the opposite side. Metastasis is the easiest. M0, there is no distant metastasis. M1, there is distant metastasis. If you see M1 or distant metastasis, this is stage 4 lung cancer, which is not fun. Staging for small cell lung cancer by the Veterans Affairs Lung Study Groups, or VALSALVA. What's that? Oh, I'm sorry, VALSG. So, non-small cell lung cancer with the T and M, you had T1, T2, T3, and N and M. But for small cell lung cancers, either limited or extensive, which is so easy. God bless those veterans. Limited disease. The tumor is confined to the ipsilateral hemithorax. Extensive disease, on the other hand, the tumor has metastasized outside the ipsilateral hemothorax. In either case, you cannot do surgery to remove it. Small cell lung cancer is too small to be seen by the surgeon. Your only choice, your only hope is with chemo or radiation. The patient deteriorates very quickly, so do not delay the treatment. You diagnose it, you treat it right away. Don't say, oh, you can come to me in 2 months. There will be no patient in 2 months. Get your head out of your sphincter. Complications of lung cancer, paraneoplastic syndrome, metastases. Where does the primary lung cancer metastasize to? Number 1, hilar lymph node. This is painless lymphadenopathy. Number 2, the adrenals. Number 3, the liver. Number 4, the brain. Number 5, the bone, causing osteolytic lesions. Cachexia. by cachectin or TNF-alpha, interferon gamma, and interleukin 6. Anemia is usually normocytic, normochromic with normal MCV. What's the normal MCV? Between 80 and 100. If you are naive, if you are super sophisticated, say 76 to 96. I don't care. Complications of the treatment and, unfortunately, death. Lung cancer is the most common cause of cancer-related death in the United States. Prognosis. The prognosis of non-small cell lung cancer is way better than the small cell lung cancer. Non-small cell lung cancer. 5-year median survival rate is 10 to 15%. Translation. 15% of patients will live for 5 years or more after having the cancer. Small cell lung cancer, the 5-year median survival rate is horrible. 10% if it's a limited disease, only 1 to 2% if it's an extensive disease. Translation. 98% of patients with small cell lung cancer will not live for 5 years. That's horrific. How to manage non-small cell cancer and how to manage small cell cancer. Non-small, it depends on the stage. Stage 1, surgery, it's called lobectomy, chemo, platinum-based chemotherapy, not to be confused with plant-based radiation, it's called post-resection radiation. You remove the tumor first, then you radiate. Radiation may reduce the recurrence of the cancer, but it does not prolong survival. Next, stage 2, surgery, chemo, radiation. Stage 3, surgery, chemo, radiation. Stage 4, when there is distant metastasis, only palliative care. It's too late. If cancer is positive for EGFR, or ALK, you can use a targeted therapy. Of course, it's going to be super expensive. There is a difference between using a chemotherapy called arsenic, which is in the periodic table. You just throw it at the patient and it hits everything. Or you can use a very targeted therapy to target a specific freaking receptor. Arsenic is not that expensive. EGFR targeter is going to be super expensive, which makes perfect sense. Next is the post-treatment follow-up. For the first 2 years, you do a physical exam and chest x-ray 4 times every year. So every 3 months, the patient has to come and see it. The 3rd year, the 4th year, and 5th year, chest x-ray twice a year. More than 5th year, chest x-ray only once a year. You can substitute CT scan for 1 chest x-ray per year. So during the first 2 years, instead of chest x-ray 4 times a year, you can do 3 times chest x-ray and 1 time CT scan. How to manage small cell lung cancer, chemo or radiation, it's inoperable, it's so small to be seen by the surgeon. Pancoast tumor location, if you have a tumor on the lung apex. Histopathology is most commonly squamous. Clinically, you can have Horner syndrome. Why? Because it can press on the sympathetic chain. Symptoms, you have ipsilateral ptosis, meiosis, and hydrosis. Upper limb weakness and shoulder pain because it can impinge on the brachial plexus, which contains sensory fibers leading to shoulder pain and motor fibers leading to upper limb weakness. Superior vena cava syndrome is a medical emergency. You can have a primary lung cancer pressing on the superior vena cava. It's most likely small or could be squamous. Lymphoma or secondary lung cancer can do the same thing. Or a non-malignant cause such as goiter, aortic aneurysm, fibrosing mediastinitis, and even benign tumors. Pathogenesis of superior vena cava syndrome. Small or squamous lung cancer pressing on the superior vena cava. Less blood is draining from the upper body into the heart. As you know, superior vena cava drains head and neck and upper extremities. This will lead to congestion of the veins in the upper body, leading to swelling of the face and neck. This is the jugular vein. And even swelling of the upper extremity and the shoulder at that side. This will lead to opening of venous collaterals or venous anastomosis because this area is congested. This will lead to appearance of visible distended veins on the anterior chest because of the anastomosis. Blood will ooze into the capillaries and leak into the surrounding tissue, leading to cough and dyspnea. Less blood returning to the right atrium will cause hypotension. How to diagnose superior vena cava syndrome? You have vital signs, tachypnea, tachycardia, and hypotension. Inspection, you find the face is swollen and puffy. You'll find the neck swollen, the shoulders are swollen, the neck veins are distended, and the anterior chest wall is having visible distended veins. You can palpate the veins. You can do a special test called Pemberton sign. You ask the patient to raise both arms above his head. Normally, nothing is going to happen. In superior vena cava syndrome, a positive test will show facial swelling, neck swelling, cough, dyspnea, respiratory distress, and even cyanosis just by raising your arms above your head. This is superior vena cava syndrome. Please do not confuse Pemberton sign with positive Addison sign. Positive Addison sign is seen in thoracic outlet syndrome when you have a cervical rib or a lymphosarcoma, which is an old term for lymphoma. Abduction and external rotation of the shoulder will lead to absent radial pulse. Back to superior vena cava syndrome, you can do radiology, CT scan with contrast. Complications of superior vena cava syndrome: tracheal obstruction, respiratory distress, hypotension and tachycardia, cyanosis, retinal hemorrhage, and even stroke. How to manage this ugly disease? If it's mild case, head elevation and diuretics to drain the excessive volume, endovenous stent. For severe cases due to cancer, palliative therapy, because this cancer has went too far, it's too late. Some clinical pearls. My favorite part of the lecture: cigarette smoking is the #1 risk factor for lung cancer, both first-hand and second-hand, but they are not the same. First-hand 85%, second-hand is only 5%. Male smokers have a higher risk to develop lung cancer than female smokers. Non-smoking related lung cancer has high incidence among women than men. Example, adenocarcinoma. The more cigarettes you smoke, the greater your risk. It's called common sense. Don't smoke, guys. The longer you smoke, the greater your risk. So, the amount and the duration. If you stop smoking, your risk of developing lung cancer will decrease dramatically, and it will continue to decrease as long as you don't smoke again. But your risk will never be the same as a person who has never smoked before. So don't get started. Your PFTs will improve when you stop smoking, but they will never be as good as a person who has never smoked. When they first introduced the cigarette filters, people thought that it will dramatically reduce the incidence of lung cancer. It never happened. The problem is when you put a filter on the cigarette, okay, the filter is going to filter the big particles, but the small particles will continue to pass, no matter how good the filter is. Back in the good old days, which were not so good, before the filter, we called it bronchogenic carcinoma. It was here because the particle was large. After the introduction of the filter, small particles passed, so the cancer happened here. Okay, so yeah, it did reduce the risk of cancer, but only slightly. The main difference is that instead of having a proximal cancer, now you will end up with a distal cancer. Just don't smoke, people. Cigarette and asbestos synergism for primary lung cancer. Smoking alone, you have increased the risk by 10-fold. So, I've never smoked a cigarette in my life. My risk of developing lung cancer is less than 1%. Also, I don't have any family history of lung cancer. A person who smokes has 10-fold, so 10x. So, your risk of getting lung cancer is 10%. Patient who has been exposed to significant amount of asbestos have 6x, so 6% risk of having lung cancer compared to me. But if a patient is smoking and was exposed to lots of asbestos, he will have 60-fold increase in lung cancer risk. So now he has 60% of getting primary lung cancer. This combination is called synergism. 1 + 1 = 3, which is a mathematical insanity but a pathological reality. Asbestos-related lung disease most commonly lead to benign pleural plaque with or without pleural effusion. The most common cancer related to asbestos is not mesothelioma, it's primary lung cancer. The second most common is mesothelioma. Mesothelioma is not related to cigarette smoking. I hate cigarettes, but I don't lie. Cigarette smoking, you'll get lung cancer and many other cancers, but you will not get mesothelioma. Mesothelioma is related to asbestos exposure, though. Asbestosis does not increase the risk of tuberculosis. The most common lung cancer is secondary lung cancer. It's the metastasis. Mesothelioma related to asbestos but not cigarette smoking. Death rates in mesothelioma is lower in smokers than non-smokers. So here is the deal. Everything in life has pros and cons, even cigarette smoking. But here is the caveat. Smoking has hundreds of cons, but only 2 pros. Number 1, if you were exposed to asbestos, you're less likely to die from mesothelioma if you are smoking cigarettes. Why? Because you're more likely to develop and die from lung cancer early on before you get mesothelioma. You got it? If you are smoking, you have less incidence of ulcerative colitis, but more risk of Crohn's disease. If you are smoking, you have a lower risk of getting dementia because you will die earlier. I'm sorry, don't smoke, guys. I am sorry that the video was long, but hopefully you learned something. Please subscribe, hit the bell, smash like, follow me on Facebook. I have 100 cases there. You can get my premium videos, my cases, my post notes, my PDF notes, including the slides of this video and every other video, available at patreon.com/medicosis. Thank you so much for watching. As always, be safe, stay happy, and study hard. This is Medicosis Professionals, where medicine makes perfect sense.